Okay, hello and welcome to the SHSMD Webinar, Doing More with Less, Redefining Audience Targeting with AI and Predictive Analytics. SHSMD would like to extend a sincere thank you to Causeway Solutions for sponsoring today's program. This webinar is now being recorded and is broadcast in listen-only mode. We have allotted time at the end for Q&A, but feel free to click the chat icon in the lower right-hand side of your screen to submit questions or comments throughout the presentation. It is now my pleasure to introduce today's speakers. Tom Kirby oversees the analysis of consumer, market, patient, financial, and clinical data sets to better engage consumers and patients in the most effective and efficient way. His team manages all of the marketing department's key data sets and is responsible for identifying trends and opportunities, understanding individual consumer and patient journeys, demonstrating ROI for marketing campaigns, and providing strategic market guidance to service line, hospital level, and executive leadership. Tim Duer leads market research, audience analytics, AI, and data management for healthcare clients. As a former physical therapist and operations director of ambulatory practice at a large multi-hospital health system, Tim uses his balanced background of hands-on clinical care and business understanding to develop novel approaches to the rapidly evolving healthcare marketplace. Tom and Tim, thank you so much for joining us. The floor is yours.
Thank you all.
Great. Thanks, Tom. So as Tom introduced us, Tom and Tim, we're going to make this as confusing as possible with three names that all sound the same. But again, Tim Duer, I'm with Causeway Solutions, and I'm going to lead sort of the beginning half of our discussion here with Tom chiming in, and then we're going to sort of flip roles on the back half of the conversation. General objectives, we're trying to look to really understand first what the tool of predictive analytics provides for the marketing audience in healthcare space. We're going to try to make this as general as possible. Certainly some of the work that Tom and I do together is specific to what UPMC can do, but we really want to make sure this presentation talks about how predictive analytics provides potential future opportunities for all healthcare systems across the board. And just want to pause there for 1 second too. We're going to go through some of these slides fairly quickly. There's a lot of really interesting background research that you don't need to take notes on. You don't need to worry about catching the detailed nuance. All of these slides are going to be shared with everybody that's joined today right after the presentation ends. So please don't worry about the details as we move through these things. So first, the background of why we're having this conversation, and none of this is new to anybody that's on the call right now, but obviously with the budget challenges facing hospital systems right now, the losses are mounting and everybody's trying to react and see what can be done to improve margins. When we pulled this together a little bit earlier, they were looking at potentially minus 37% when it comes to margins looking versus pre-pandemic. And really the expectations are falling to those of you that are on the calls right now of, all right, we need to increase volume, we need to do more, but by the way, we're shrinking the budget when it comes to Marcom. So what are we going to do with it? And the realities is now there needs to be a shift towards how can we be more efficient and faster and better and drive more value from these conversations when it comes to marketing.
And I would just add to that, you see drive growth and volume with a rapidly shrinking budget. I always tell the story when I got here maybe 6 years ago, just over 6 years ago, we were still doing so much targeting towards our consumers, towards this sort of general, women 45 plus healthcare decision maker audience, who, help shrink the pool from everyone 18 or 24 plus. But what ended up happening is that, that women 45 plus healthcare decision makers, they were the only audience that we were reaching. And so we were talking to the same group, no matter what the service line, no matter what the message was. And so as we'll talk about here, this, what we've been working to better do over those last 6 years is shrink that pool. Not only shrink the pool to target the right audience, but deliver that right message at the right time, and do so without tapping into patient data or anything that would, even blur the lines with a HIPAA violation. So it's kind of the coming together of both becoming more efficient and doing so in a HIPAA compliant way.
Yeah, absolutely. And so really what it comes to is now there's kind of a new growth in the idea of how can these analytics tools be used and really make it work for the masses. And like Tom said, it's really looking who is a potential patient And some of that, as we talk through the slides, I'll tell some of my backstories. But really, everybody is a potential patient, but who is it that you really want to reach? Who is the audience that you really want to focus your efforts on? Who's that patient potential that has the best cost of acquisition? Not just anybody could be our patient. And like Tom said, the other part is being more personal in your connection. We've all become so used to digital marketing tools that do reach us on our personal level. And that's a big difference for people. I think we really need to push that conversation more of people expect personalization, but just like Tom said, that gets really tricky when you're dealing with a HIPAA-based environment. You can't be personal based on what you have on your health records. So instead, you need to look outward of what personalization tools, how do you connect with somebody using them as a consumer, not as a patient? Obviously, a lot of this is made possible due to the advances of machine learning and AI. And yes, they are buzzwords that everybody wants to talk about. But really, when we go through this, I'm not going to get in the weeds of it because God knows I'm not the person you want talking about the detailed algorithms and codes and all of that. We have a team that does a great job with that. But really, the fact that they can do these things now and use some of the massively large quality data sets lets it show that there's possibilities here. And again, it all really comes back to the idea of marketing teams need to be able to do more with less. And I think that's a big change. And it is possible. It's just not by going back to the same plan, same actions. So I think we're going to pause there. Tom B, I think if we can put the poll question up. Kind of as we move on to the next slide, there was one question I wanted to ask. When we're discussing more advanced analytics for your marketing efforts, who is it in your organization that does that? Is it an outside consultant? Is it a department within the hospital that really focuses on marketing insights and analytics? Is it somebody on your marketing team that they're the ones that know how to use Excel and you go with that? Or is this not really something that most people are doing right now? The more advanced analytics are not part of the marketing jargon for you yet. So we'll kind of move on a little bit of the background of modeling as people are responding there. Really, again, probably could have asked the poll question of, do people really know the term modeling or predictive modeling? And we'll talk about some of the history of that as we go through here. I don't want to get in the weeds too far there, but the idea of modeling is something that really generates very individual insights. It is predictive and prescriptive in the sense that it's not a guarantee. These aren't surveys where it just says, Tom says yes, Tim says no, or like the poll you're responding to right now, where it looks like most people are answering what analytics as things are starting to fill up. That is a poll. I don't know who answered that question. I don't know how it differs between person A or person B that answers any of these things, but it gives me the insight as you're responding to say, well, where are people falling in this poll? The difference is when we talk about predictive models, we start applying those scores on an individual level of who is likely to say what analytics, who is most likely to say we use an outside consultant. And when you start getting into those individual pieces of things, now you can start decreasing that marketing spend by knowing who we should talk to because we've predicted these are the people that are being most responded. So we say it a lot that polling helps you make a strategic decision. You look at the masses and say, is there an audience for this or is there not an audience for this? But modeling then says, now that we see we have a potential action to take, what are the next steps? Who should we be talking to? So this is definitely one of those slides where I'm not going to go through the whole thing right now, but for those of you who do find this more interesting, I think it's really eye-opening that the way we come about this, and I'm going to give this as the very short version, is a modeling project, as we call it, eventually results in everybody in a certain region being scored as their probability to feel a certain way, hold a certain belief, have a likelihood to take an action. And again, I will probably use the word likely to a lot of times in the presentation today, because again, these are not guarantees. These are predictive. They are likelihoods. We're trying to find the best audience, not the guaranteed audience. But to get to that final application piece, we have to start somewhere. And as Tom alluded to, none of this is using HIPAA protected or medical record data. Instead, we're doing a custom survey. In this instance that we'll talk about today, some of it is custom just for UPMC, but then there's other things we at Causeway do on our own to collect that then can be used by the masses. But any sort of predictive modeling project has to initially start with data development and data collection. What are the goals we're trying to accomplish? What are the audiences we're trying to build? And I'll show you some examples of those in a little bit. But ultimately, you have to determine what those goals are. Then step 2 becomes data collection. If we're doing a national project, that'll be collecting at least 6,000 people across the country. We're going to get a large variety of people to respond to these questions and answer how they feel they would answer. In some cases, again, with UPMC and Tom, it might be just their footprint, we call it, of the UPMC reach within Pennsylvania, New York, Maryland. We're being more narrow in how we approach it. But the key here is these are not anonymized surveys. They are connected to the consumer file. And the consumer file becomes the important part when we move from step 2 to 3 here of combining the respondents with the consumer group. And so your national consumer file, as somebody who operated as a clinician for 20 years, there is way more information on all of us when it comes to our consumer behaviors than there is about our healthcare behaviors. We could debate that in a completely separate conversation, the pros and cons of that. But as a consumer, we have opted into so many things that we don't even realize. Your credit card, where you purchase things, all of that is compiled in a consumer file. You can opt out of these things, but most people don't. But what that means is when we're collecting our data to build a predictive model, we've got over 450 lines of data on most people that we can then match it back to. Not just where they live, male, female, and basic demographics, but also what things do they have positive flags for, what type of things they shop or what they have shown interest in by purchases they've made, things like that. And that's all built in the consumer file. And then where the machine learning and AI piece kicks in is building these models and universes, which means now we're going to say we collected from 6,000 people, but how do we apply scores? What are the rest of the 250 million consumers in the country likely to do? And now everybody in the country now gets a score of what their likelihood to take that belief or take that action or hold that belief is. And now that's when the power kicks in. Obviously, this is a fairly complicated process that, again, whole courses taught on it from the data analytics standpoint. And it used to be very limited on how these were applicable. It was outside of politics, which we'll talk about in a little bit. It was only used really by select organizations that really had more mature marketing capabilities. One of the coolest things is the fact that that data collection step is really where the bulk of the cost used to live. It wasn't so much in making the models, it was collecting the data. If we're going to collect data that attaches to a person, it used to have to be nothing but phone calls. And that got really expensive to ask everybody to call. Well, now what we've been able to do is there's more organizations now connecting this with online surveying. And by doing that alone, it really improves the ability to create these things in mass, make it much more affordable for others to use. And now companies like ours and others are starting to build these predictive models that don't require a custom build. And that's really a game changer going forward. And honestly, for most people in healthcare, that's truly why you haven't heard about predictive modeling very much, because it wasn't something most people had access to in the past. So I'm going to pause there quickly. We'll look and see where our poll did finish up. And yes, it looks like the bulk of people were the what analytics. So not a surprise. And again, this is a new concept, which is why I'm happy to be able to share this today. So before we talk about what type of models or audiences we create, I want to back up one little step here. And when Tom did talk earlier about, previous market segmentation of, we're going to reach every head of household female 40 years and older because we know they are the most likely to be making a decision when it comes to the health of the family. But that's really a demographic view of things. You're taking what you can easily get through Facebook. If it's digital, you can easily buy a list. You can use your own internal data sets and say, we're going to segment. And, I came from a pediatric health system background. Okay, if they have a child in the household and their income is in this range, that's who we're going to reach. Well, that's fine. It is segmentation and it's great, but it's not using really the behavioral piece. So typically in demographics, if you look here, we can say, all right, well, we want to target mothers over $150,000. So we can take these two groups in green and dark blue out. But if we leave that whole group together, we're still not really narrowing it down. There's one group that already has made their decision that they're doing what you're going to hope to ask them to do, whether it's use your pediatric system, whether it's to make a purchase when something that's not health related, whether it's voting in a political campaign. There's another group that has no intention. You are not going to spin them over. You're not going to pull them to unless you have a chance to go door to door and really have a conversation. They have very little to no intention of taking a certain action. Not to say you can't market to them, but odds are it's going to be a wasted resource at this point because the amount of lift it takes to get them to do it gets too complicated. The key is this group in the middle. The people that aren't quite sure, they're on the fence on the decision. They're not sure if they will or will not do that. In any sort of a marketing campaign, if you can identify this audience and put as many of your marketing resources into this group, now you're getting the most bang for your buck. But if you just stopped at the known demographic level alone, you really have no idea from a behavioral breakdown. You only know they're in who we're predicting from a persona view is likely to take that action. So That's really a big difference. And what that leads to then is now we can move to a place where individuals start looking similar and different because that's the way we all are. We have things where we overlap. So I love this example that we built of if we take these two people on the surface, demographics look completely different. Mr. Franklin Smith here, 62-year-old widower, Caucasian, lower income under 100,000, between 50 to 100. So on the surface, these two people would never be in the same campaign because Miss Jane Doe over here is 28 years old, married, no kids, higher income. Nothing about her and Franklin look the same. But when we apply some of these ideas of predictive models and do the scoring and put them in universes, neither one of them have a primary care doctor. Both of them are modeled to use urgent care about 3 or 4 times, be likely to use it about 3 or 4 times a year. Both of them would rather use a larger academic system, not a local. Both of them prefer to use a national retailer for their pharmacy services. But there are some differences. Jane prefers convenience versus Franklin really is looking for a good bedside manner in his providers. Franklin's a highly likely user of endocrinology. Jane's a high likely user of orthopedics. So again, demographically, you would never, ever run a campaign that is segmented down to include these two people. But if we're trying to push an idea of people that need a PCP, they both would be in that audience. They're both potential targets. But on the surface, you never would have put them together. And so these are a few examples, kind of in general, what we have that we're working with right now. And again, these are available not just through Causeway, but through other places now that are starting to use this to build models that are applicable to the healthcare consumer en masse. And I just put these up again. We're not going to go through them all. But again, as you see, my favorite one, and we spent a lot of time really thinking through and working with Tom and his team to do it first with UPMC alone and now for the nation, is, there's different drivers of choice. I use this one example all the time. There was a hospital near me that really was not known to be a high quality hospital at all. I don't think they knew what they were doing, but they had a great billboard out front that told you how many minutes you had to wait for their emergency room. And it typically was less than 10 minutes because, again, not the hospital most people would want to rush to, but they were really marketing their convenience. We're right here. The billboard's here. We're telling you have no wait time. Come on out. They didn't have the ability to market their quality. If they talked to people about how great they are, it was going to be a short conversation. But by looking at the driver of choice, again, people that are really primarily driven by quality, people that it's about the ease, or there's people that really want that bedside manner. And no one person is only one of those buckets, but models kind of help us figure out who is really primarily driven by any one of these things in particular. One of the newest concepts we're doing, again, most likely to use a specialist probably stands out to a lot of people. And this is one that took us a long time to figure out how to approach these types of problems, because this is something that typically, as a clinician, I could have easily told you who these people are with one look at somebody's medical record, even if they haven't been to a cardiologist. Let's look at their blood pressure. We know they should be going to a cardiologist. Completely different is asking the entire country of have you gone to a cardiologist in the last year? And we start building these models on, well, we know Tim said yes, Tom said no, but now we do this in mass and we start applying these scores and we can start modeling somebody's likelihood to use the specialist without ever touching their medical file. And again, many of you, I'm sure, have felt like those HIPAA handcuffs can be challenging sometimes. If you could figure out who you want to reach, and your service line marketing teams are saying, but I know who I want to talk to, but you can't always use that information because you shouldn't. It's HIPAA protected. This was a way to say, well, let's just find out who's likely to do it by survey, not worrying at all about their medical record. So kind of share this one with Tom a little bit. This is just some examples. So those on the previous slide are all different types of models that are built from the healthcare consumer across the country that have no relevance to a specific healthcare system. These are some of the ones that Tom's team and my team work together on that are really very specific to how UPMC is viewed. So Tom, I don't know if you want to talk about these briefly.
Yeah, absolutely. And, just talking about the upper left, think about things, really, I should say the whole top row are building models based upon where consumers are on the marketing funnel, essentially, everywhere from awareness, in our markets, in Pennsylvania and slightly in just out of the state, we don't necessarily have an awareness problem. However, as we move down, into preference, consideration, we have a lot of great competitors, and we're in a number of different unique markets compared to one another. Competitors are less in one, we've got more competitors in others, et cetera. So understanding where people fall in the consideration set, in the preference set, et cetera, helps us, reach them with like, because Tim has been saying, with the right message on top of that. When we know that consumers have a positive opinion of UPMC, believe that we've got the best care possible, but aren't using us, we can start to look at our models and into our research that we have to understand, all right, what are those reasons that they might not be using us? Seems like they're coming all the way down that funnel, checking all the right boxes for us, but just aren't using it. Is it do they not know that we're nearby? Are they with another competitor? What are those levers that we need to pull? And this is, again, Tim has mentioned a couple times, we could go in a whole other seminar, about this type of thing, but this involves a lot of qualitative research we do with these different segments as well, depending upon how important a campaign is, how much budget we have for it, really starting to dig down and understand what those messages are that, as Tim showed in the prior slides, are going to make people make those decisions to use us for care, use us more often for care, use us for different lines of care that maybe they're going to somewhere else. How can we continue to move them towards more usage and more loyalty for UPMC?
And so one thing, I'm going to pause there, and we have another poll question that Tom B can drop in there. But one thing, as we're talking about this now, again, I'm sure everybody in this call is doing some sort of segmentation in your marketing. I would hope, you're not relying purely on billboards to hit everybody in your region. But for those that are doing something beyond demographics, what are people using? Is it many people, honestly, it's more channel specific. You're letting the platform itself take things and run a bit. Facebook can help you find these audiences by using their own more detailed segmentation, which a lot of that then relies on their online persona, following through with that. The other group, I know a lot of companies or hospital systems are letting the media agency take this and run. Can they find a good digital audience for you and use some of these tools? But you're putting the ball in their court. And honestly, I know there's a lot of groups that really just are stopping at demographics. It's what's available to them, and it does provide segmentation. Again, I know in my past, that was what we did a lot. I could figure out from a geographic region of, the system I was with, we know that here's the geography. Do they have children in the household? And some sites we could take Medicaid, some sites we couldn't, so we might have an income cut. And that was essentially what we were using to do our audiences. So, I'd love to see people's feedback. And it looks like right now a slight lead going with the, people letting the media agency work through some of that filtering. And again, that's truly what I've seen when I've had these conversations with lots of health systems, that, they're hoping the media agency is getting the most efficiency as possible. So one more background slide.
I would just, sorry, Tim, just to jump in, I would say as everyone thinks about this and thinks about their own business, and where you might fall on the spectrum that's in the pool, et cetera, we didn't just jump off the deep end and start to build some very, we now have some very, very specific, very, very unique segments and audiences that we built, but we didn't start that way. Our first goal was getting beyond that. I'll use the same example over and over again, getting beyond the women 45 plus likely healthcare decision maker demographic, buys that we were doing, and just start to get, I will use that analogy a lot too, like shrinking that ocean. It was baby steps at a time. How can we do a little bit, get a little bit smarter, get a little bit more efficient, get a little bit more targeted. And as we and our team, other teams internally here got comfortable with that and started to see those successes. Okay, how can we take that to another level, How far down this rabbit hole can we go down and still see positive results, positive ROI compared with just doing, blanket demographic buys? So, as we go through this, I would say don't get discouraged if you start to feel overwhelmed by some of the capabilities. There's a great place to start, I think, for everyone to start thinking about this.
Yep. And with that, to the other part, I forget if we mentioned, or I think Tom B may have mentioned, if anybody has questions on any of these things, please feel free to throw it in the chat. We may or may not stop along the way, or we might pick them up at the end. But if something pops to you that sounds, interesting, or you're not quite sure with it, please don't hesitate. If you haven't figured it out by now, Tom and I are kind of freewheeling in our presentation skills here. So happy to pause and cover anything. So this slide here is honestly one, when I started with Causeway a few years ago, I was kind of scared to bring up because it becomes so polarizing. But then I realized actually it is what makes the most sense for people. Really, when it comes to predictive modeling and the use of this in marketing, politics is where it has begun and where it's done most commonly. We don't even think of it. And the reason I say that is when we think of, I live in New Jersey, and I will tell you with the election that happened yesterday, we were in a key area where they were just inundating us with flyers and mailers. And we're not talking about the TV ads that are hitting the masses, but the more focused, targeted audiences with direct mail and digital especially. Or I even got some wonderful text messages that were flooding my phone. But the idea of politics is there is a very known group that is a hard Republican, strong GOP, and there is a hard Democrat, left-leaning liberal group that neither one of the other parties really wants to market to. A hard Republican voter is not going to be swung to vote for the Democratic candidate. So the Democrats are not going to send anything to the people in this column here. That makes sense. The key is, believe it or not, when it comes to voting, that's what all the models are doing, is they help make sure they know who those people are with most likelihood to start taking them out, because that's where the directed audiences happen. But the interesting part with politics is because of voter histories, what they can apply is also models on what's their likelihood to take an action, which is pretty simple when it comes to politics, of vote or not vote. And what that leads to is really a couple different categories. You've got a strong group of people, let's call it give or take 10%, that fall into this hard Republican or hard Democrat group. They are going to be not necessarily targeted, but they're going to be targeted if they to turn out if they're falling in these buckets of there's not somebody who votes a lot, but if they did, they're going to vote for a Democrat or Republican. But only one party is going to be reaching out to those groups. You've then got this group in the purple. They're leaning Republican, they lean Democrat, or they're neutral. But the part that makes them the most important is they at least have a moderate to high likelihood that they're going to vote. So both parties are now fighting it. This is the group that's getting double messaged from everybody because both parties have identified them as somebody who votes regularly, but we're modeling them as saying they're leaning and they're not sure. So they are going to spend almost every dollar each party has goes to the people in these 6 boxes. Sometimes it'll filter down into this bottom group. But the interesting part with this bottom group is they don't tend to vote. So they're the least likely to vote, which means even if they sway them to the left or right, the harder part is getting them to actually get out and do it. So they're not always the group that gets targeted because even if they agree with them, they're not taking the action somebody wants. And then the other part that gets left out a lot are these 2 white boxes in the top corners. White boxes in the top corners are basically who both parties know are guaranteed we've got these voters. And they, not that they don't want to reach out to them, but they already know they're going to vote and they're going to vote in their hands. They might be reaching out to say, will you put a sign out front? Will you go door to door for us? Those kind of things. They're looking at these people to be volunteers. Somebody who is a hard Democrat and votes in every single election possible doesn't need to be asked by the Democrats to go out and vote. They're pretty confident in that. So, and that's a really interesting space that typically I would say most, and Tom will talk about this a little bit in the upcoming slides, but honestly, most people outside of politics, and that includes general commercial and enterprise, and we do work with non-healthcare systems as well. This is a hard pill to swallow for some people, in the sense that, well, but if I just talk to somebody long enough, I can convince them to use UPMC. Or if I just told them, it's a short drive, we can get them to use our system and come more. You could, but the reality is marketing dollars right now don't allow for that constant on high frequency touches that it takes to move some of these audiences. And most people, again, think, well, if I just had a chance. But the reality is politics has been playing this game for a long time. They know they're not moving the hard right over to the left. They know they're not moving the hard left to the right. We can have another conversation about the state of the country and what that means. But the reality is both parties for a long time have made sure they identify that swing conversation of who lives in the middle. And that's the group they're trying to speak to. And I think the more health systems or other marketing teams outside of politics can recognize that, that's really where you can get the best ROI on some of these things. Now you can start reaching these people more times to get them to convert or to get them to click through or try, because it's not an easy lift for this group, but they are reachable. So with that, we're going to kind of roll into, I'll let Tom kind of take lead here. And this is basically the exact same matrix that you just saw for politics. And with Tom's organization, UPMC, we've now applied those same rules in many ways as they start thinking about their audiences?
This, like I said, we can get very, very complicated. We've got a sort of a two-dimensional grid here. It's funny. We can apply all of these other dimensions to this to start creating these unique audiences. But for the purposes of this call, let's take a look at this as, like I said, just two-dimensional with really two universes here. Universe one is, sort of vertically there, someone who is not using UPMC or is hardly using UPMC, if at all the way up to those who are heavy users. And then from left to right, those who are, would consider using UPMC, from the right-hand side, or I should say strongly consider, all the way to the left-hand side, who, for one reason or another is really not willing to give UPMC a try. Where, when we think about our budgets, does everyone in here get spoken to in different ways? Sure. But where we need to invest our limited marketing budgets, we focus in on those three colored segments that are in the middle there. And the first one, and I would say the most important one, is what we look at as the adoption group, that group on the far, the lower right-hand side, that's a group willing to use UPMC. But for one reason or another, they haven't, either they haven't yet or they don't use us a lot. And I'm not talking about healthy people here. They're not using us because they, I would, I'm fine. We're talking about people that, like, we want to get into not just PCP, but make sure that they're using us for the more acute care as that happens. That affinity group in the middle is like it says, mid-use, mid-consideration. This has always been an interesting group to watch how they move over time. Are they going to, is our message going to get them to pull the trigger and use us a little bit more? Or is it going to start to change their hearts and minds a little bit and start to consider us a little bit? So watching that audience move either north or east, I should say, is always very interesting to go by. And then we've got that loyalty group up at the top who they're already using us a lot. However, they are, in that, willing to slightly unwilling, to consider using us in the future. And that's a group that we want to continue to build stronger loyalty with, and drive them to that upper right-hand bucket, our quote unquote, our super users in the top right, who, as Tim mentioned on the prior slide, these are, they have a staunch opinion. They're always going out to the polls. This is a group of, these are our ambassadors who are out there, and we use our other tools such as, the messaging that they're already getting a lot of information from UPMC, and what we don't want to do is continue to inundate them. Their experience is going to be what continues to drive and keep them in that super user segment. So this is where we use things within our portal, making sure that we're talking and maintaining more of an experience with them instead of a marketing driven conversation.
And I will add one thing too. When we're talking use here, this is based on sort of the surveys, the data collection, just like with any model. This is not connecting to the actual health file to say, Mrs. Jones came 5 times, so we know she's high use. We're constantly looking at ways to remain HIPAA compliant with that. But the initial matrix we're looking at here is really built off those modeled behaviors, not the actual behaviors. And that's again, a challenge for many people.
And we often talk about that L group. Perfect segue here, that, look, what are we trying to do with this group? We're trying to get this group to move right in some way. We want to move them, like, improve their consideration, improve their positive experiences, their positive opinions of UPMC and our care, so that they're using us more and becoming more of a loyal ambassador. That group in the bottom left, that's a long, arduous journey to take them on. And so again, we still reach them with our, broader, broadcast, more broad media that we're doing with that group. But again, in the world that we live in, we want to continue to use the fishing analogy. We want to be able to fish where the fish are. We want to make our marketing dollars go where they're going to have the greatest impact and greatest ROI as we can right now. And that's why we spend it on the other audiences more.
And typically when we're building an audiences together, these are the first groups that go, right? It's not an automatic, but if we're trying to get down to an audience size of the budget allows for 25,000 people, well, these are the groups that we're going to look to take out to make sure we hit the numbers that really matter. And another interesting point when it comes, Tom.
No, I was just going to say, one of those reasons, when you look at something like low use or low willingness to consider, one of those reasons that are in there is is my insurance accepted at UPMC? And more and more, especially in Pennsylvania, people are making a decision on where they're going for care. The most important factor is, first and foremost, is my insurance accepted? And there are groups in there who, frankly, could come to UPMC, but they just don't realize it with their insurance. So there are ways to dig into this audience. I'm not saying that we ignore it. There are ways to dig in to understand this L group more and deliver right messages that might be most apt to drive someone to the right. But again, in our budget conscious world that we live in, it's a trade-off that you have to decide.
And I think the other important point here is this super user box is basically where any social media platform, if it's kind of left to its own devices, that's who it's going to focus on, because that's the group that is going to click on the UPMC ad. That's great. But if your goal is to get clicks, this is the group that's going to do it. If your goal is to actually generate growth and acquisition, these are the people that are already there. We worked with a big box retailer, and I would joke a lot of the time, like, well, but these are the people that are already sitting in your parking lot right now. Do you really need to send them a coupon as they're walking in the door? They were already taking the action. But again, because of the built-in channel-specific algorithms, they are going to migrate everything to the group that's most likely to like, comment, share, etc. But that might not be the group you're trying to get if you're trying for growth. This is a retention group. This isn't a growth group.
Yeah. And to Tim's point, that's an important conversation you need to have, and that we have with our team internally, as what is the ultimate KPI that we're looking for? Because if you're not careful, your media agency is going to be optimizing towards clicks, which means you might be optimizing towards that super user and not really growing your volumes in any way. You're speaking to the group that's already in your waiting room. And again, that's why we need to focus on more of the down the funnel KPIs to help us understand, hey, we're talking to this group. We know that the click-through rates might not be as high as our super user, but this is the group that's going to drive the volume and increase our share as we face this competitive world that we live in our markets.
So one last poll question we're doing. This comes from personal experience, where one of my last fights I had while I was still in the clinical world was honestly trying to convince one of our high up administrators that we just didn't have the budget to move a certain audience. So my question is, do you think you could talk to your leadership team and be able to tell them, hey, we need to not try to reach this group, even if they look like they could be our ideal, they're not there? Or B, would it take a lot of work? You're really going to have to come to the table with a very good explanation because they think more reaches is better. Or is it C? And honestly, I know there's a lot of agencies out there, especially, that have felt like, when I've had conversations, that no, we've just got to reach the masses, period. And it's not about cutting anybody off, but the idea of not reaching someone there. So I think it's an interesting role here, but I do think it is a challenge I've become more aware of over and over again, that there are plenty of decision makers that really are still, we just got to reach the numbers and see where it goes. So interested to see people's feedback there. All right, so Tom, I'll let you keep running here.
Yeah, we again, this idea of saying the right message to the right person at the right time, we have lovingly called this idea our Mad Libs, where we can create these these different segments to understand who they are, what they want, what do we want them to do, what is the message that's going to be most appealing to them, where do we want them to go, etc. So again, thinking not just by geography, which I don't want to discount, because as we know, convenience is playing an ever-growing importance in where people are choosing to get their care. But where they live, what they think about the system, what they think about in terms of their own care or the unique care that's provided by the system. What do they actually need? And what's going to drive them to make those decisions. So as you can see, again, quote unquote, our Mad Lib on the right, Jane Doe is a medium rate UPMC user with moderate favorability. Since she lives in the adoption target, we're going to reach her. We're going to target her with focused messaging about orthopedics content by talking to her about quality or regional care. And that, as we get down that, or in the term, as we get down that Mad Lib a little bit more, this is where that further research. So as we start to identify our segments, and I don't want to say demographic segments, I don't even want to just say psychographic segments, as we understand these behavioral and attitudinal segments that we have, how can we do further research with them to understand, all right, beyond just this group that we've got, there are subsegments in there that are going to be more responsive to messaging that's about a topic, and some that are going to be more resonant about messages that are about B topic. And this is where this comes from, where we know that some of our audience is going to get a message about quality. Some may get a message about convenience. Some may get a message about, Tim mentioned the one example earlier about bedside manner. There are different drivers that are going to make people, stop, at least consider, maybe make that decision, maybe click on that, click on that button to call us, et cetera.
And I think Tom mentioned before, that matrix we showed there is 2 dimensions. I've been talking lots more now about like the 3rd dimension, or turning it into a Rubik's cube, because that tells you really, like Tom was saying, who to talk to. But the messaging part, that's really the complicated, that's where it starts feeling more personalized, when you can add that, who's likely to stick with the message. And honestly, the sky's the limit when it comes to how specific to get to this. I mean, Tom and I have joked that, what was it, 10,000 different messages to 10,000 different people, which is doable. Then it becomes, how do you not drive your agency team crazy, because now I want 10,000 specific, contacts. All right, so kind of talk through when this more advanced view of an audience is good, and when, maybe it's not so good.
Sorry, I was looking real quick. I was seeing the question in the chat here about how do you know the consideration data? Is that via third party or bespoke research? For the most part, we do bespoke. We do a lot of custom research, but we also use syndicated partners out there like NRC to understand these things as well. But in the case of building our audiences, it's from the unique specific polling that we do to help generate those audiences. So again, you got it. Just as important as when to use audiences are really when to avoid using advanced audiences. Again, we don't fall down the rabbit hole to say every campaign is necessarily primed for an audience. Like, when do we avoid these? Well, broad campaigns, when we're doing maybe our brand messaging, et cetera. We, not surprisingly, we're based out of Pittsburgh, so we do a lot of sponsorship and buys with the Steelers. There's not a lot of segmentation that goes on to those TV buys. Small campaigns where we're only going after a few zip codes, there it becomes all about convenience. We may not have the budget or may not have the time to, zero in a little bit more on specifics or extremely narrow targets. As Tim said, we could create 10,000, if not more, different segments, but you kind of reach the point of diminishing return, on your investment in some of those cases. So when to use advanced audiences, there are 2 distinct groups of people who would benefit from those different messages. We've done, more than just, 2. We've got an example coming up of using multiple different subsegments with multiple different messages. And when we're trying to drive an action with that, within that narrowed audience, again, there are many, many opportunities for us. In fact, it's kind of fun. We've now reached a point with, our clinical teams, et cetera, where, they come in with an idea, and, the first question that they're asking is like, hey, what audiences can we start to build with this? Where are those ways that we can continue to shrink that ocean a little bit to get at the audiences that we want specifically, the right group that we want. Again, as it says there, other notes, we often use lookalike models to continue to extend that reach. We work with our media buyers. We work with our partners in order to do that. Again, think about those differences between reach and performance between channels. Again, what is the right KPI that you're going after? You might have to forego some reach. You might have to forego some click-through rates in order to make sure you're getting at the right audience to take the right action that you want. We use audiences where we create audiences basically to exclude certain folks from our messaging as well. We do a lot of that with, again, likelihoods. As Tim said, always important to use that term likely, because we're not grabbing this from our own internal data. This is all modeled data. But if there's an insurance group, as I said, out there that doesn't offer access to UPMC, we want to make sure that we are not essentially wasting marketing dollars by sending a message to them when they can't even use us. That's just going to drive confusion and frustration with them. And then, where possible, always test. How can we use multiple creative versions so that we can continue to learn more about our audiences and about these segments as the campaign goes, so that we can optimize in a better way.
All right. And then this is really more about how does this actually work? So Tom, I'm going to let you take the lead here, and then I'll kind of jump in. But this is not just somebody asks, Tom's team delivers, and we move on kind of relationship with this. No.
Yeah, I kind of alluded to it on the last part, but I'm our strategy and insights team. We have Causeway as our key partner. We've got our service line marketers. We have our digital team that we sit with. We've got the creative agencies and the media buyers. When's the best time to start talking about this? Like at the kickoff. As the opportunity. Again, we're going to identify major opportunities through our planning process every year, for the following year. But there are always going to be those opportunities. Always going to be, a department has found money. We want to, we want to go after this group, or we've identified a drop in volumes for this service line in this market. What can we do to help bring that back? So when we have those kickoffs, that's the best time to have those conversations. So right at the beginning, not only can we be thinking about who the right audience is that's going to, take the action that we want or be the most valuable for us to go after, but all of our partners can be thinking about, from the creative standpoint, what are those messages? How do we want to bring these messages to life? Our media team can be thinking about, where are those places that we need to buy? What are those optimizations that we want to build into the creative as we go? And then our, those three purple bubbles right there of our internal groups, we want to make sure we're all speaking the same language, so that we're creating the right KPIs and setting up the right sort of analytical checks for the best success.
And I think in many cases,
long-winded way to say, do it right from the start.
Yeah, because honestly, I was just saying, one of my first things I usually jump in is, the service line team will ask for something very specific. We need people with this GI diagnosis to take this medication because they're potential targets for this surgery. And my answer is always, well, no, we can't do that. But let's talk about that. Let's tell me more about what they're looking for. Is it people that buy a lot of fast food and they're high risk? There's always different ways to get to it. So in many cases, it's not an easy, obvious answer. The no but is often what happens on some of these kickoff calls. Of we don't have exactly what you're looking for because that violated a lot of HIPAA code, but instead we're going to take this different spin and we can get there. No,
right.
We don't need to stay on this one too much, Tom, but maybe just a quick rundown of, does it help?
Yeah, and we've seen positive ROI, across the board, with our audiences compared to just sort of the standard audiences that we would buy through Facebook or other partners like that. Again, we continue to see positive successes. I'll say that second line there under the big percentages. We created 115 unique audiences in 2021. Through this year alone, we've already created 284 audiences.
We only have a few slides left. So if anybody's thinking of that question, if we haven't answered it yet, we're probably not going to answer it now. So go ahead and start typing those in the chat if something's hanging in the back of your head there. I'm going to skip ahead. And to this one, I think, Tom, we already alluded to is, the benefits of an advanced audience is a little different. If you're doing direct mail, it's to just move further down the funnel, stop wasting flyers, versus digital is giving you the option to do that Rubik's Cube of, can you cross over and do specific messaging that resonates, even though there's, say, multiple people in an audience. And so this last slide, and then I'm going to do one more after that, but the last one here, Tom, maybe you can talk about. This was a cardiovascular campaign that it was easy to pick out who to target, but that dimensional piece really made a big difference of how to target them.
Yeah, exactly. So we used, again, only model data that we had, or based on the consumer data, nothing, nowhere using any of our patient data. But we created 3 audiences here for a heart and vascular campaign that we built. Number one, high risk adults, any adult 35 plus, that also scored higher for likelihood to be overweight, not likely to exercise, more likely to be a smoker. We had 258,000 individuals in that audience. The lapsed care group, thinking about, many people have started putting off a lot of care. There's a whole other discussion about care deferment that we could talk about since the pandemic. This is that lapsed care group, adults 35 plus, who likely stopped attending their annual checkups, over the last few years. This audience actually, was the most efficient in terms of cost per conversion, 21% lower than the other audiences. So, this was a group that was clearly ready to re-engage. Our message was enough to make them think about, all right, what have I put off? Yeah, maybe it is time for me to get my butt in gear and get back into the doctor's office and get a checkup. And then the underserved. So we looked at Black Pittsburghers, 35 plus in low income zip codes throughout the Pittsburgh, metro market. The reach was small, but very, very qualified. And again, that conversion rate was 28% higher than other audiences. And this is really those opportunities where you can use the models, to make sure that we are, or I should say, are not excluding certain audiences from our broader campaigns, and delivering message that is uniquely tuned to them and speaks to them as a group as well. And as you can see, 28% higher than success with the other audiences in terms of conversion.
And so then the last one, we're going to go back and hope this actually works. There it is. So just showing, again, we've kind of done a mix in this conversation of some of the things that are, how does predictive analytics and modeling work? What can the masses use? What's available to all of you on this call and anyone else? And then there's another part, which is very customized to how UPMC takes this to the next level in many cases. But just to show demonstration wise, this is a pretty interesting tool we've been working on, that if we can take the entire country, 241 million consumers are on file. And the reason that's important is this is consumer-driven decision-making. If you're trying to find a pediatric patient, this doesn't work. This is much more about the marketing side of things, which means it's adults only. So we have 240 million people, 119 million households that are on file. But that's a big reach, obviously. So one way is you can narrow things down by geography. But now when we start adding these other aspects in, so consider yourself to be overweight. This is now something we surveyed, we created as a model saying, this has no HIPAA issue. This was not taken from anybody's medical record. Based on the surveys we did, 41% of the country has answered that that's the way they feel, and we can see that. But now I can narrow that down and say, if just for convenience, now we want to see in Alabama, it's a little bit higher, 45%. And I want to see, I have no idea where Baldwin County is, but in Baldwin County, it's 43%. And these are just the numbers to give us an idea. But if I'm working with a health system in Baldwin County, Alabama, who's trying to discuss their bariatrics program, right away, we now say there's actually 98,000 people in your county you want to speak to. There's 43,000 or 43% of those people. We can then look at the age range. Now we could start adding a demographic cut of saying, well, the procedure you're going to talk about isn't covered by Medicaid. So immediately you could say, let's take out 28% of the consumers that are here that are less than $50,000 as an income. Thank you to someone who knew Baldwin County right off the bat. But these are the other aspects that, to me, I think the coolest part of this is previously you had to start with the demographics and, kind of hope you landed on the right people. And instead, when you start with something like a likelihood to have a behavior or take a belief, you're starting way ahead of the game. Then you can decide, do you want to do this? So if we talk about cardiology, let's get rid of Baldwin County and go to all of Alabama. We have 22% of the population in Alabama, falls into a group where they are more likely than others to need cardiology. Well, most of you, if you ever run a cardiology campaign, I'm sure it's going to be age 55 and up, give or take. Sometimes it's even higher because you narrow it down by tightening up your age parameters. And although it's not huge, but that means right here, there's 6% of people that are in Alabama that we modeled as being highly likely to use the cardiology, but they're falling below where your persona based on demographics alone would have had. Not a big deal, but we're talking about heart surgeries. This is 6% of people you would have never sent a message to because they didn't fall in the maybe group. On the flip side, there's some people that are in 55 to 64, but not a lot. But now you start doing that. So instead of just having to slide that scale to find your audience size purely on surface level, you can start being smarter and thinking through other ways to get to that. And again, it's not quite this simple, but it can be. And I think like Tom and I alluded to in that previous slide, that the biggest key is it's a long conversation on these. Sometimes it's, I just got to get there quick, so let's be fast with it. Other times it's, we've got a major campaign and we really need to think through and be conscious of it and take advantage to everything. And again, I really come from the background of, I love value-based care. And to me, this is how value moves out of the treatment side of things and moves into the administration side for a hospital. Let's be more value-driven in who we're reaching, how we're reaching them, and what can we do. So with all of that, we'll kind of pause there. There was one question that came directly to me that I want to make sure I cover for everybody. The question was, how does your product ensure HIPAA compliance, particularly in light of the Department of Health and Human Services ruling regarding HIPAA and website tracking technologies? So I will start, and Tom can jump in a little bit, but that was everything freeze at UPMC, pull all pixels off, just like all of you probably did or should be doing. Although I did see there's a pushback happening now. But to answer the question, how does this that we're talking about today apply, is all of this is done for the consumer, not based on any health piece. And like we said, when we're talking about use, I don't know, and neither does Tom, if people actually were high frequency users of UPMC, because we can't track that through the medical record. We also can't track who's landing on the page at a cardiovascular campaign after it runs, because those things aren't able to be tracked because they shouldn't be. And again, I take HIPAA very seriously coming from a healthcare background. But what we're doing here is by, as I said in the how do we get here, we're doing a survey nationally. People are opting in to respond to that survey and give the information. We're working with that surveyor at all times to make sure our questions never cross the barrier. And there's been ideas that my team has had, and I said, no, we can't go that far. Like that's becoming invasive. But we keep it general, and then you use that predictive model. Again, we don't know that they use UPMC at a high rate, but we know we now have a good likelihood that they do. And again, this is marketing. The things we're doing here are not going to meet the needs when I was publishing things as a clinician, because they don't have that p-value of 0.05 or less all the time. But we're talking about marketing. Yeah. Anything you can do to narrow it down is better, but we have to make sure we stay within those parameters. Anything else?
Yeah, I know this sounds like, just too much love for the group I work with, but it's, really work with a passionate group who is really, who really comes to work every day to help people. And so, again, we take HIPAA very, very seriously here. I think, we actually review everything that we do with our legal team, and our privacy group as well, to make sure that, we're, like I said earlier, we're never stepping into a gray area. We want to make sure that there is no doubt everything that we're doing is on the up and up in terms of HIPAA goes. And yeah, as Tim said, we did, those Google and Facebook pixels came down pretty darn quick. And we've worked on, with our digital team and with frankly, our legal team on what those right options would be as replacements over time. But yeah, it did, and again, it was as a consumer, it was a great conversation to have. As a marketer, it makes things a little more difficult, but yeah, it did stop our ability to really start to track back some of that true ROI. We're working on ways to be able to do that again legally, of course. But that's in progress, as is probably with many of you out there as well.
And I would say, when Tom and I looked at this earlier this year, of like the increased rate of the number of audiences being pulled by us to help his team is keeps growing, and probably some of that goes to the fact that there now is limitations on retargeting because of this pixel. So instead, we have a complete firewall with what we're providing Tom and his team from a marketing perspective, and there is no connection ever to what actually happened, which includes who clicked through but didn't, versus opt-ins, all that stuff. So we keep it a pretty, very tight firewall between the two discussion points there. All right, well,
I know Tim has his name listed at the bottom too. If anyone, on the client side would, sits in the same position as I do, wants to talk offline, I'm more than happy to grab a virtual coffee and talk more about it with you.
Yeah, and absolutely don't hesitate for either one of us, because this is really just the tip of the iceberg on how do these things work. And for many of you, appropriately, I'm sure this is the first time you've heard some of these concepts and ideas, and I could talk about it all day. So amazing that Tom and I actually wrapped this up right at 2:00. That's a small miracle. No.
All right. Well, Tim and Tom, thank you both so much for joining us and sharing your expertise with us today. And another big thank you to Causeway Solutions for sponsoring today's program. Please make sure you complete the short survey that will launch on your browser once this webinar closes. And a recording of this webinar plus the slides will be shared later this afternoon via email. And that concludes today's presentation. Thank you, and wishing you all a great afternoon ahead.
Thank you
all.